Impulsivity is a multifactorial construct that involves a tendency to act on a whim, displaying behavior characterized by little or no forethought, reflection, or consideration of the consequences. Impulsive actions are typically poorly conceived, prematurely expressed, unduly risky, or inappropriate to the situation that often result in undesirable consequences, which imperil long-term goals and strategies for success. A functional variety of impulsivity has also been suggested, which involves action without much forethought in appropriate situations that can and does result in desirable consequences. When such actions have positive outcomes, they tend not to be seen as signs of impulsivity, but as indicators of boldness, quickness, spontaneity, courageousness, or unconventionality. Thus, the construct of impulsivity includes at least two independent components. First, acting without an appropriate amount of deliberation, which may or may not be functional, and second, choosing short-term gains over long-term ones. Impulsivity is both a facet of personality and a major component of various disorders, including autism, ADHD, substance use disorders, bipolar disorder, antisocial personality disorder, and borderline personality disorder. Impulsiveness may also be a factor in procrastination. Abnormal patterns of impulsivity have also been noted. Instances of acquired brain injury and neurodegenerative diseases. Neurobiological findings suggest that there are specific brain regions involved in impulsive behavior, although different brain networks may contribute to different manifestations of impulsivity, and that genetics may play a role. Many actions contain both impulsive and compulsive features, but impulsivity and compulsivity are functionally distinct. Impulsivity and compulsivity are interrelated in that each exhibits a tendency to act prematurely or without considered thought and often include negative outcomes. Compulsivity may be on a continuum, with compulsivity on one end and impulsivity on the other, but research has been contradictory on this point. Compulsivity occurs in response to a perceived risk or threat. Impulsivity occurs in response to a perceived immediate gain or benefit, and whereas compulsivity involves repetitive actions, impulsivity involves unplanned reactions. Associated behavioral and societal problems. Attention deficit hyperactivity disorder update needed to reflect updated version of DSM. Attention deficit hyperactivity disorder is a multiple component disorder involving inattention, impulsivity, and hyperactivity. The Diagnostic and Statistical Manual of Mental Disorders breaks ADHD into three subtypes according to the behavioral symptoms. Attention deficit hyperactivity disorder, predominantly inattentive type. Attention deficit hyperactivity disorder, predominantly hyperactive impulsive type. Attention deficit hyperactivity disorder, combined type. Predominantly hyperactive impulsive type. Symptoms may include fidgeting and squirming in seats, talking non-stop, dashing around, touching or playing with anything and everything in sight, having trouble sitting still during dinner, school, and story time, being constantly in motion, having difficulty doing quiet tasks or activities, and also these manifestations primarily of impulsivity. Be very impatient, blurt out inappropriate comments, show their emotions without restraint, and act without regard for consequences. Have difficulty waiting for things they want or waiting their turns in games. Often interrupts conversations or others' activities. Prevalence of the disorder worldwide is estimated to be between 4% and 10%, with reports as low as 2.2% and as high as 17.8%. Variation in rate of diagnoses may be attributed to differences between populations, and differences in diagnostic methodologies. Prevalence of ADHD among females females is less than half that of males, and females more commonly fall into the inattentive subtype. Despite an upward trend in diagnoses of the inattentive subtype of ADHD, impulsivity is commonly considered to be the central feature of ADHD, and the impulsive and combined subtypes are the major contributors to the societal costs associated with ADHD. The estimated cost of illness for a child with ADHD is $14,576 annually. Prevalence of ADHD among prison populations is significantly higher than that of the normal population. In both adults and children, ADHD has a high rate of comorbidity with other mental health disorders such as learning disability, conduct disorder, anxiety disorder, major depressive disorder, bipolar disorder, and substance use disorders. The precise genetic and environmental factors contributing to ADHD are relatively unknown, but endophenotypes offer a potential middle ground between genes and symptoms. ADHD is commonly linked to core deficits involving executive function, delay aversion, or activation arousal theories that attempt to explain ADHD through its symptomology. Endophenotypes, on the other hand, purport to identify potential behavioral markers that correlate with specific genetic etiology. There is some evidence to support deficits in response inhibition as one such marker. Problems inhibiting prepotent responses are linked with deficits in prefrontal cortex functioning, which is a common dysfunction associated with ADHD and other impulse control disorders. Evidence-based psychopharmacological and behavioral interventions exist for ADHD. Substance abuse. Impulsivity appears to be linked to all stages of substance abuse. The acquisition phase of substance abuse involves the escalation from single use to regular use. Impulsivity may be related to the acquisition of substance abuse because of the potential role that instant gratification provided by the substance may offset the larger future benefits of abstaining from the substance, and because people with impaired inhibitory control may not able to overcome motivating environmental cues, such as peer pressure. Similarly, individuals that discount the value of delayed reinforcers begin to abuse alcohol, marijuana, and cigarettes early in life, while also abusing a wider array of illicit drugs compared to those who discounted delayed reinforcers less. Escalation or dysregulation is the next and more severe phase of substance abuse. In this phase, individuals lose control of their addiction with large levels of drug consumption and binge drug use. Animal studies suggest that individuals with higher levels of impulsivity may be more prone to the escalation stage of substance abuse. Impulsivity is also related to the abstinence, relapse, and treatment stages of substance abuse. People who scored high on the Barrett impulsivity scale were more likely to stop treatment for cocaine abuse. Additionally, they adhere to treatment for a shorter duration than people that scored low on impulsivity. Also, impulsive people had greater cravings for drugs during withdrawal periods and were more likely to relapse. This effect was shown in a study where smokers that test high on the BIS had increased craving in response to smoking cues, and gave into the cravings more quickly than less impulsive smokers. Taken as a whole, the current research suggests that impulsive individuals are less likely to abstain from drugs and more likely to relapse earlier than less impulsive individuals. While it is important to note the effect of impulsivity on substance abuse, the reciprocating effect whereby substance abuse can increase impulsivity has also been researched and documented. The promoting effect of impulsivity on substance abuse and the effect of substance abuse on increased impulsivity creates a positive feedback loop that maintains substance-seeking behaviors. It also makes conclusions about the direction of causality difficult. This phenomenon has been shown to be related to several substances but not all. For example, alcohol has been shown to increase impulsivity while amphetamines have had mixed results. Substance use disorder treatments include prescription of medications such as acamprosate, buprenorphine, disulfiram, LAAM, methadone, and naltrexone, as well as effective psychotherapeutic treatment like behavioral couples therapy (CBT), contingency management, motivational enhancement therapy, and relapse prevention. Eating. Impulsive overeating spans from an episode of indulgence by an otherwise healthy person to chronic binges by a person with an eating disorder. Consumption of tempting food by non-clinical individuals increases when self-regulatory resources are previously depleted by another task, suggesting that it is caused by a breakdown in self-control. Impulsive eating of unhealthy snack foods appears to be regulated by individual differences in impulsivity when self-control is weakened by attitudes towards the snack and towards healthy eating when self-control is strong. There is also evidence that greater food consumption occurs when people are in a sad mood, although it is possible that this is due more to emotional regulation than to a lack of self-control. In these cases, overeating will only take place if the food is palatable to the person, and if so, individual differences in impulsivity can predict the amount of consumption. Chronic overeating is a behavioral component of binge eating disorder, compulsive overeating, and bulimia nervosa. These diseases are more common for women and may involve eating thousands of calories at a time. Depending on which of these disorders is the underlying cause, an episode of overeating can have a variety of different motivations. Characteristics common among these three disorders include low self-esteem, depression, eating when not physically hungry, preoccupation with food, eating alone due to embarrassment, and feelings of regretted disgust after an episode. In these cases, overeating is not limited to palatable foods. Impulsivity differentially affects disorders involving the over-control of food intake and disorders involving the lack of control of food intake. Cognitive impulsivity, such as risk-taking, is a component of many eating disorders, including those that are restrictive. However, only people with disorders involving episodes of overeating have elevated levels of motoric impulsivity, such as reduced response inhibition capacity. One theory suggests that binging provides a short-term escape from feelings of sadness, anger, or boredom, although it may contribute to these negative emotions in the long term. Another theory suggests that binge eating involves reward seeking, as evidenced by decreased serotonin-binding receptors of binge-eating women compared to matched weight controls and predictive value of heightened reward sensitivity, driving dysfunctional eating. Treatments for clinical-grade overeating include cognitive behavioral therapy to teach people how to track and change their eating habits and actions, interpersonal psychotherapy to help people analyze the contribution of the friends and family in the disorder, and pharmacological therapies including antidepressants and SSRIs. Impulse buying. Impulse buying consists of purchasing a product or service without any previous intent to make that purchase. It has been speculated to account for as much as 80% of all purchases in the United States. There are several theories pertaining to impulsive buying. One theory suggests that it is exposure combining with the speed that a reward can be obtained that influences an individual to choose lesser, immediate rewards over greater rewards that can be obtained later. For example, a person might choose to buy a candy bar because they are in the candy aisle even though they had decided earlier that they would not buy candy while in the store. Another theory is one of self-regulation, which suggests that the capacity to refrain from impulsive buying is a finite resource. As this capacity is depleted with repeated acts of restraint, susceptibility to purchasing other items on impulse increases. Finally, a third theory suggests an emotional and behavioral tie between the purchaser and a product, which drives both the likelihood of an impulsive purchase as well as the degree that a person will retroactively be satisfied with that purchase result. Some studies have shown a large number of individuals are happy with purchases made on impulse, which is explained as a pre-existing emotional attachment which has a positive relationship both with the likelihood of initiating the purchase as well as mitigating post-purchase satisfaction. As an example, when purchasing team-related college paraphernalia, a large percentage of those purchases are made on impulse and are tied to the degree with which a person has positive ties to the team. Impulsive buying is seen both as an individual trait in which each person has a preconditioned hereditary allotment, as well as a situational construct which is mitigated by such things as emotion in the moment of the purchase and the preconditioned ties an individual has with the product. Psychotherapy and pharmacological treatments have been shown to be helpful interventions for patients with impulsive-compulsive buying disorder. Psychotherapy interventions include the use of desensitization techniques, self-help books, or attending a support group. Pharmacological interventions include the use of SSRIs, such as fluvoxamine, citalopram, escitalopram, and naltrexone. Impulse control disorders not elsewhere classified. Impulse control disorder are a class of DSM diagnoses that do not fall into the other diagnostic categories of the manual, and that are characterized by extreme difficulty controlling impulses or urges despite negative consequences. Individuals suffering from an impulse control disorder frequently experience 5 stages of symptoms: compelling urge, a desire, failure to resist the urge, a heightened sense of arousal, succumbing to the urge, and potential remorse or feelings of guilt after the behavior is completed. Specific disorders included within this category include intermittent explosive disorder, kleptomania, pathological gambling, pyromania, trichotillomania, and impulse control disorders not otherwise specified. ICD-NOS includes other significant difficulties that seem to be related to impulsivity but do not meet the criteria for a specific DSM diagnosis. There has been much debate over whether or not the ICDs deserve a diagnostic category of their own, or whether they are in fact phenomenologically and epidemiologically related to other major psychiatric conditions like obsessive-compulsive disorder, affective disorders, and addictive disorders. In fact, the ICD classification is likely to change with the release of the DSM-V in May 2013. In this new revision, the ICD-NOS will likely be reduced or removed. Proposed revisions include reclassifying trichotillomania and skin-picking disorder as obsessive-compulsive and related disorders, moving intermittent explosive disorder under the diagnostic heading of disruptive impulse control and conduct disorders, and gambling disorder may be included in addiction and related disorders. The role of impulsivity in the ICDs varies. Research on kleptomania and pyromania are lacking, though there is some evidence that greater kleptomania severity is tied to poor executive functioning. Trichotillomania and skin-picking disorder seem to be disorders that primarily involve motor impulsivity, and will likely be classified in the DSM-V within the obsessive-compulsive and related disorders category. Pathological gambling, in contrast, seems to involve many diverse aspects of impulsivity and abnormal reward circuitry that has led to it being increasingly conceptualized as a non-substance behavioral addiction. Evidence elucidating the role of impulsivity in pathological gambling is accumulating, with pathological gambling samples demonstrating greater response impulsivity, choice impulsivity, and reflection impulsivity than comparison control samples. Additionally, pathological gamblers tend to demonstrate greater response perseveration and risky decision-making in laboratory gambling tasks compared to controls, though there is no strong evidence suggesting that attention and working memory are impaired in pathological gamblers. These relations between impulsivity and pathological gambling are confirmed by brain function research. Pathological gamblers demonstrate less activation in the frontal cortical regions compared to controls during behavioral task stacking response. Impulsivity, compulsivity, and risk are reward preliminary, though variable. Findings also suggest that striatal activation is different between gamblers and controls, and that neurotransmitter differences may exist as well. Individuals with intermittent explosive disorder, also known as impulsive aggression, have exhibited serotonergic abnormalities and show differential activation in response to emotional stimuli and situations. Notably, intermittent explosive disorder is not associated with a higher likelihood of diagnosis with any of the other ICDs but is highly comorbid with disruptive behavior disorders in childhood. Intermittent explosive disorder is likely be reclassified in the DSM-V as under the heading of disruptive impulse control and conduct disorders. These sorts of impulse control disorders are most often treated using certain types of psychopharmacological interventions and behavioral treatments like cognitive behavior therapy.